Hello friends, you must have all encountered problems in calcaneal fractures, whether they are related to wound complications or sometimes symptomatic hardware. Even if you have reduced the fracture perfectly and placed a good implant, even then the patients often complain about the symptoms like heel pain, swelling, irritation over the implant, and often difficulty in shoe wear. So how does the story start? The story starts with a displaced articular calcaneum fracture. You see the fracture, you see the x-ray, you find out that the articular chunk has been displaced, then you plan for the surgery. You go for the extensile lateral approach for reducing the articular chunk perfectly and placing the calcaneum plate, but how it ends? It ends like this. There is necrosis at the suture line, and often this terminal area or the apex of the incision has the tendency to go necrosis. And if you're unlucky, then often the implants get exposed at this part, and then the story ends only after removal of the implant. And often the patient undergoes several surgeries, limiting their quality of life and your experience also. So while you had planned for a good surgery, the things don't look like a wow. So these are some photographs of the complications of calcaneal fractures. You see the wound necrosis is the common complication, and this terminal part or the apex of the incision of the extensile approach is the main location of the wound complications, while the marginal necrosis is often seen all around the incision in most of the cases. And even if your soft tissue handling is good and if you are good at the wound healing outcomes, then also the patient often complains about the symptomatic hardware. Like you see in this picture, the wound is perfectly healed, but that doesn't mean that the patient will not have any symptoms. So the calcaneal fractures are bound to have some or other complications even when the reduction is good and the implant has been placed correctly. So you see in this radiograph, the reduction is done perfectly, the implant is well placed. In this also the implant is well placed, and in this also the implant is well placed without any articular malel reduction. Even the alignment of the calcaneum is good. Still the patient complains that he is having pain in this area despite of your all efforts. Let's identify what the problems are. So we are facing wound complications, too much of the hardware which is probably not right for the thin skin cover over the heel. And what about the malel reduction? Does that really matter? We'll see. So let's go to the basics. What are the principles of articular fracture fixation? We want a good reduction of the articular surface, just like this puzzle has been solved perfectly. Then what we want absolute stability at the articular surface. That means peri-articular construct should be a rigid one. And what about the extra-articular bone? Even relative stability with a good alignment will help in good healing in this part. So our aim is to achieve anatomical reduction at the articular facet. While in remaining part, that is tuberosity, we can go for relative stability. That means the fixation need not to be a rigid one. It just needs to fulfill some criteria that are required for proper alignment of the tuberosity. So just imagine what you want to do in this kind of fracture. So we want this articular facet which is depressed to be lying somewhere here. That means congruent to the undersurface of the talus, while the tuberosity needs to be restored in an alignment that needs to be perfect with the remaining part of the foot. So there are some angular parameters. The critical angle of Gissane, which is the angle between the anterior process of the calcaneum and the posterior facet. So this angle is highly variable. It varies from patient to patient. You can actually make the articular facet parallel to the undersurface of the talus. That will tell whether the angle of Gissane has been restored perfectly or not. What about the Bowler angle? Bowler angle is actually meant for the alignment of the tuberosity with the remaining part of the calcaneum. So if the tuberosity has gone up, this angle is going to get reduced. This angle is between the anterior-most apex of the anterior process of calcaneum and the top part of the posterior facet. From the top part of the posterior facet, we go towards the topmost part of the tuberosity. So the angle that is created here, the acute angle, should be 20 to 40 degree. This angle is important because if you are restoring this angle, you are actually restoring the adequate amount of tension in the tendinoachilles. If you are not restoring this, that means the tendinoachilles is going to be lax. Also, if you are going to restore this angle, then you are actually restoring the pitch of the calcaneum also. You see, the calcaneum is tilted upwards. That means the anterior process is actually facing upward, while the tuberosity is lying downward. If you are not restoring this angle, that means you are actually making the calcaneum flat, and that will ultimately result in patient symptoms because the biomechanics of the foot have been altered. So why these angles are important? The foot is actually like a tripod. Here the top part is representing the midfoot area that includes all the tarsal bones, while the posterior part is representing the calcaneum, tuberosity part of the calcaneum. The anterior two limbs are represented by the first metatarsal on the one side, while the other metatarsal in a series represent this limb of the tripod. If you see the cross section of the CT of foot, you see the alignment is like this. This is the first metatarsal, while these are the remaining metatarsals. So they are aligned at a particular angle, like an arc. So what if you are not able to restore the articular surface perfectly? So mild amount of Malel reduction is well tolerated in Calcaneum. That can be understood from the fact that several studies in the past have shown superior outcomes with the conservative management or non-operative management of the displaced articular fracture of Calcaneum. But if you are not able to restore the tuberosity part perfectly, that means the tension in the tendon necklace, the overall tripod construct of the foot, then definitely the patient is going to have symptoms that are going to bother you. So we should be worried about the calcaneum pitch. That means the tuberosity should have angulation in an upward direction anteriorly so that the tension in the tendon necklace has been adequately restored, like you see in this normal radiograph. Second, what you can do, you can draw a horizontal line from the posteriormost part of the undersurface of the talus. The tuberosity topmost part should always lie below this line. Like you see in this normal radiograph also, it is lying here. If you are not able to restore this part below the horizontal line, that means you are actually making the tendinoachilles relax, and the patient will have difficulty in generating the pull that is required in the heel off stage, or you can say push off stage, when the patient tries to lift the heel up. So definitely that is going to create symptoms of pain in the calf muscle also, and automatically the stress distribution in this zone will be altered and the patient will have symptoms. So what are the materials that we have for achieving our target? So for restoring the articular surface and providing absolute stability near the articular surface, we have the locking plates available in variable sizes. These are the old ones and these are the newer ones, which are more malleable compared to the conventional Calcanean plates. And recently the low profile plates, or you can say sinus tarsi plates, have been made available, which are very small and do not pose major hardware prominence because they are already pre-contoured according to the Calcaneum shape. Then we have the locking screws also that can be used for providing stable construct in the periarticular region. So are we missing something? So we have K-wires also. The 2.5 mm K-wires are thick enough to support the Calcaneum fractures. If we want the stable articular block, we have an option to put locking screw construct in this zone like this. And if we are using the K-wires are actually having hold in this part only, and this part is actually fractured. So automatically if any stress is placed here, that is going to create motion at the fracture site, and the aim of absolute stability will get hampered. But what if we span the calcaneum from the tuberosity through the posterior facet and to the talus? Then the stress will be taken up by the thick subcondylar bone of the talus. So the lever arm, which was earlier of this size, has now been reduced to this much size. Why? Because the hold is here and the motion is happening here. So the forces that are required to generate displacing movement are higher when the lever arm is very small. In the previous scenario, when the wire was like this, the amount of force required for this long lever arm was very small. But now the lever arm has been shortened. That's why the forces that are required for bringing motion at the fracture side are very high. And if we supplement this with multiple K-wires which are spanning the talus, that means the construct is going to be a rigid one. While for the tuberosity part, if there is some displacing force here, the lever arm is actually this much bigger. So there is going to be some micromotion at the tuberosity that is actually going to make it heal by the relative stability. So there is absolute stability at the articular part because of the shorter lever arm due to hold in the adjacent talus, while for tuberosity there is a longer lever arm extending from talus till here. What if the articular block has multiple fragments? Like in this picture, you see this kind of sandals type 4 calcaneum fracture in which there are several articular fragments. You see there are 1, 2, 3, 4, 5 articular fragments, and the tuberosity is also very comminuted. So in such scenarios, the K-wires that we are going to put are not going to hold each and every fragment when we are spanning the wires through the talus. So what we can do, we can supplement our fixation with the help of a screw. That can be a single screw or a multiple screw also, depending upon the bone purchase that you are getting. So you see this is a post-operative CT of the same patient. You see there was combination, and this is the CT after surgery. And you see the screw is supporting these fragments, and multiple K-wires are also spanning these fragments and getting purchased in the talus. This was the follow-up radiograph of this patient. The articular part is still congruent, while there was extensive combination at the tuberosity part. It has healed by the relative stability. Outcome-wise, the patient was fine. So after stabilizing the periarticular area, our second target was to stabilize the tuberosity, and the alignment of tuberosity needs to be restored. The lever arm is large here and there is some micromotion going on in this part, but if it is highly comminuted, then the chances of displacement are also there. So we want additional stability for the tuberosity. We are done with the article part, but you see there is large amount of bone still present here that can be used for placement of K-wires. So what we can do, we can place 2 or 3 K-wires from the tuberosity and get a hold in this part. That means the anterior process up till the subchondral bone. But if you want more stability, then you can use the same method that we have used for the posterior facet by pushing the wires till the cuboid. You see, now we are having good amount of stability just like this area. So if the tuberosity is comminuted, it is good option to put multiple K-wires in this direction also. And whenever you are committing for the K-wires placement, always check for the Exel View also. And in Exel View, you have to look for any varus alignment and any widening, because often the lateral wall blowout is there. The lateral wall is coming here under the skin, that is going to create symptoms. So once you have reduced the articular block, you have to push this bone back, otherwise that is going to create symptoms. Like in this post-operative radiograph, you see the articular facet has been reduced and the bone that would have been lying here has been pushed back inside. Same here, same here. And always use multiplanar wires. Whenever multiple directional K wires are used, they are actually providing multiplanar stability. So whenever possible, go for multiple plane K-wires because they are going to make the construct more stable. So what if the tuberosity is fragmented so much that you cannot get any hold in the K-wires? Like you see in this picture, the wires are getting hold here, but whole of this bone is actually deficient. The bone has gone downwards, translated here. In such cases, you can actually go for the plate fixation because the direction of the screws is going to be from the lateral to medial direction. That means the screws are going to get purchased on the opposite side of the bone as well. So a plate would be a good option to supplement the K-wire fixation, while additional screws to support the subchondral bone of the posterior facet can also be used. Now the tuberosity is having hold with the K-wires as well as with the plate. So the construct is going to be a stable one. This option can be used whenever the tuberosity is extensively comminuted and your K-wires are not getting good hold in the tuberosity. So by now we are aware that K-wires are good option, and these large profile plates are probably not necessary for all kind of fractures, while the Sinasi tarsi plate or a low profile plate is sufficient for the fractures of the calcaneum that are involving articular part, and also there is combination of the tuberosity because the screws fixation through these holes are supporting all the fragments. The tuberosity part has been supported by this segment of the plate, articular part has been supported by this segment of the plate, while the anterior process is getting purchased through this part of the plate. So to some extent we have now resolved the problem of the hardware by using the K-wires, and good thing is that the K-wires can be removed once healing has been evident, that is around 6 to 8 weeks after fixation of comminuted fractures, and for simple fractures it can be 4 to 6 weeks. And the Sinasi tarsi plate, which is a low profile anatomical plate shaped according to the surface of the calcaneum, can be used for selected cases in which you are not getting good hold in the tuberosity, and also in cases when the articular fragments are multiple and you want some lateral to medial screws also to support the articular facet. So now we are left with the wound complications and Malel reduction. So wound complication, why do they happen? When we go for the extensile lateral approach, the posterior part of our incision is supplied by the lateral calcaneal branches of the peroneal vessels, while the lower part, this part, is supplied by the vessels that are branching off from the posterior tibial vessels. So this area is actually the watershed area between the peroneal vessels and the tibial vessel. So whenever our incision is slightly anterior, there are chances that we are going to hamper the terminal branches of the lateral calcaneal artery, and those branches when injured can actually cause necrosis of this area. So whenever you are going for an incision for the extensile lateral approach, try to give your incision posteriorly but not over the tendon, and also keep your incision slightly downward so that you are not injuring the terminal part of the lateral calcaneum vessels. Whenever possible, avoid this approach if the fracture can be handled with close reduction or a Sinasi tarsi approach, because those don't have the problem of this watershed zone where the vascularity is critical. So how much area do we need for seeing the joint? Actually we need this much area only. Since our aim is to restore the articular surface to perfection, while the tuberosity can be handled with the indirect reduction and realignment only, then probably the sinus tarsi approach is the good thing to go for visualizing the article part. With the sinus tarsi approach, we can start our incision from the tip of the fibula, extending anteriorly just prior to the fourth metatarsal, where the anterior process of the calcaneum lies. And with the help of sinus tarsi approach, you can actually see the required amount of joint that you need to visualize for articular reduction. So you see, this is the anterior process, while this is the anterior part of the posterior facet that is still attached to the anterior process, while this is the displaced part of the posterior facet that is lying downwards and representing this part. What we can do, we can lift this part proximally and restore the articular surface under direct vision, and by doing some varus maneuver, we can actually open up the joint to see the articular surface in a better manner. And also the peroneal tendons, which lie just over this region, can be retracted posteriorly and inferiorly to visualize the joint in a better manner. And what about the extensile lateral approach? So it has to be reserved only for selected cases. Once you are experienced with the sinus tarsi approach, which you should use for the simple articular fractures of the calcaneum whenever required, then with time you will actually become confident with the use of sinus tarsi approach in complex articular fractures of calcaneum as well. So whenever you are encountering Sandler's type 4 calcaneum fractures which are grossly displaced and difficult to reduce, then only you should go for the extensile lateral approach, because the only good thing it offers is the excellent visualization of the tuberosity, the depressed fragments, and the article part as well, but at the expense of the risk of wound healing complications. So whenever you are using the extensile lateral approach, you have to go for the bone deep incision so that it raises full thickness flap. The full thickness flaps are having lower risk of wound healing complications compared to the layered flaps when you are approaching the calcaneum. And also try to keep your incision posteriorly and apex slightly inferiorly. Also, one important thing, you see the calcaneum is tilted upwards in the anterior direction. So whenever you are placing your incision in this area, don't go for the incision that is parallel to the foot. Why? Because then you'll have to retract the skin flap proximally to visualize this part, and retraction should be minimal with this approach, because excess of retraction can also result in the marginal necrosis of this incision. So whenever you are putting your incision, always take a C-arm shoot to see what is the alignment of the anterior process of the calcaneum, because then you will be able to angulate your incision properly in the anterior part, and that will help because the retraction required will be minimal to expose this part. So now to some extent we are sure that the wound complications can be handled in a better manner by avoiding the extensile lateral approach and use the sinus tarsi approach, which is sufficient to visualize the articular surface when the fragments are major ones. And for combinated fractures with several articular fragments, probably the extensile lateral approach can be used. So what about the Malel reduction? So the literature about the operative versus non-operative treatment for displaced articular fractures of calcaneum is very heterogeneous. So there is some evidence that supports the non-operative management, and there is some evidence that supports the operative management. And generally we can say that up to 2 mm of step of articular surface is acceptable. But in my experience, even higher articular step can have good outcome if you have restored the tuberosity properly in terms of varus and valgus and the polar angle and pitch of the calcaneum. So if these parameters are restored properly, then also you can have good outcomes. Also take care whenever you are operating the calcaneum fracture, always try to reduce the bump of the tuberosity on the lateral side, because that is going to hamper the shoe wear if it is prominent, because the healing will occur in that particular position only, and that bump of the bone over the lateral part is going to create symptoms because of the tight footwear, and often irritation will occur if the implant is placed. In short, you have to restore that tripod alignment that I've told you, that is supported by the first metatarsal on the medial side and the remaining metatarsals on the lateral side, and the calcaneum tuberosity on the posterior part. Avoid any varus angulation because that is going to hamper the position of the tripod. The calcaneum should lie at the center and posterior part of the tripod. If you are going to create varus, that means the tripod is going to tilt in one particular direction. And also the tension in the tendon achilles can be restored by restoring the polar angle properly. Should also be checked whenever you are fixing the calcaneum fractures, and avoid any bulky hardware in this region, because the skin is very adherent to the bone in this part, and slight prominence in this part can actually create irritation over the skin. So there is a meta-analysis by Ning et al. That compares the operative treatment versus non-operative treatment for displaced articular fractures of calcaneum. They found that the articular fractures, when fixed surgically, are going to have good radiological outcomes, but at the expense of the risk of wound complications. So always take care whenever you are operating calcaneum fractures. Your motive should be to do no harm. Whenever possible, go for low profile implants like K-wires and sinus tarsi plate and avoid the extensile lateral approach that is potentially associated with the complications. And the sinus tarsi approach should be frequently used. You should be familiar with the sinus tarsi approach for the simple articular fractures of calcaneum, and once you start doing that, you'll be comfortable with the sinus tarsi approach used in the complex articular fractures of calcaneum as well. So the take home message is to avoid surgery whenever the fracture displacement is minimal, and K-wires are good option whenever the hardware prominence has to be avoided, and spanning the wires across the talus provides good amount of stability that can mimic the absolute articular stability and has been established with the biomechanical studies also. And screws can be used whenever the fragments are multiple just to supplement the K-wire fixation, and low profile plates can also be used whenever there is extensive combination and the wire hold is not adequate. Then to supplement the wire fixation, you can use the low profile plates. And sinus tarsi approach can be used for articular surface reduction. For complex articular fractures, probably the extensile lateral approach is good option in an experienced hand. And always take care whenever you are creating flaps over the lateral side. They should be full thickness flaps deep to the bone, and avoid any excessive retraction, poor handling of the tissues that can result in wound healing complications. I hope this video will be helpful. If you have any queries, you can just put those in comments. I will be happy to answer those. Thank you.